Mr. Chairman, ladies and gentlemen, it's a great pleasure to be here. Actually, the purpose why I'm in Singapore is that I'm participating in the Singapore General Hospital Nuclear Medicine update, which is taking place these days. And also there is opening of the cyclotron of the Singapore PET and Cardiac Imaging Center, which takes place today. And I think it's a great event and will provide nuclear medicine and PET with new isotopes and better facilities. I'm coming, as you heard, from Bad Berka. Bad in Germany means spa, so it's a beautiful place, as you can see here. Our hospital is actually located between Frankfurt, about 2.5 hours by train from Frankfurt, and Berlin, so in the middle, in the former eastern part of Germany. Is an 800-bed hospital, and we have there what we call a multidisciplinary neuroendocrine tumor center. This is one of the most important features when you are treating neuroendocrine tumors, that you have to work very closely together. Different specialists like internal medicine, gastroenterology, endocrinology, oncology, and also, of course, surgery, which is first, discipline which treats actually usually with a patient, but also interventional radiology, which becomes more and more important, for example, for treatment of liver metastases by embolization therapy or radiofrequency ablation and other methods, and also nuclear medicine, which is involved in the diagnosis as well as in the treatment of tumors. So we have there a panel of specialists in our center, and we are discussing each case before we start therapy together and try to find out what is the best therapy. This gives you a little view of our hospital. As I mentioned, it's an 800-bed hospital. Here is our PET and SET and PET-CT nuclear medicine department, which was, by the way, also founded 10 years ago. So we, had our anniversary actually in 98. In May this year, we had the 10-year anniversary. And our nuclear medicine ward, which is the largest in Germany and has 22 beds, is located here with a beautiful view over the river valley, which is called the Ilm River. In Germany, it's obligatory that any patient who receives radioactive treatment is treated as an inpatient, which is different from other countries where, for example, radioiodine is given on outpatients, but we have to keep every patient in our ward. It's a really beautiful new ward, and I think many neuroendocrine tumor patients appreciate that very well. I would like to divide my lecture into two parts. The first part is more on the principles of this treatment, to explain it, and on the diagnosis of neuroendocrine tumors, which I think is very, very important, as you heard already from Bill, and thank you very much for inviting me to this event. It's a very underdiagnosed disease. Many patients present just with metastases in the liver or in lymph nodes, and then there is some tissue taken out, and it's called an undifferentiated tumor and treated as such. And since we have new methods of diagnosis like immunohistochemistry and so on, it's now diagnosed more and more. And the man who created all this idea and the principle is Paul Ehrlich, who was born in Poland but lived then as a German professor in Frankfurt, Germany. And he created the so-called side chain theory. And that was at his time as a pathologist in Strasbourg in France, when he was working with tissue staining. You all know hematoxylin eosin staining. Everybody is using that HE staining till today. And that was created by Paul Ehrlich, to characterize certain cells and to differentiate cells from each other by using colors. And by using these, it came to his mind that there might be at the cell what he called amboceptors, so specific, structures which take up the colors. And from that he developed the theories that also bacteria, for example, work on the same way, that they bind to cell and, intoxicate cell, and develop together with Behring, what we call a vaccine against polio and diphtheria and tetanus. So I think it's a very important step forward. And he also had the first idea of what we call today tumor markers. These are substances given from the cell into the bloodstream, as you can see here, and that we can measure these specific, tumor markers in the bloodstream. So he created what the word Wunderkugeln in Germany, which is magic bullets in English, and said, substances are working only if they bind specifically to the cell. Corpora non agunt nisi fixata. This is Latin language, and means that all these amboceptors and the antitoxins, how he called it, must be worked together. And this is exactly the principle what is used today when we are speaking about a peptide and a ligand binding to a cell, or an antibody, and the antibody ligand. So he received the Nobel Prize in 1908, also about 100 years ago, and this was a groundbreaking idea and basic principle. Now, about 18 years later, Shelley, who also won a Nobel Prize for detection of LHRH and also of somatostatin, was also, by the way, born in Poland, developed the ideas that the somatostatin receptors are localized not only in the pituitary gland and the hypothalamus, but also he showed that they are present on certain tumors. And these tumors were then called neuroendocrine tumors. These are tumors which build usually hormones which are given into the bloodstream. And the most important hormone you all know is, for example, insulin. So a tumor arising from the pancreas and localized in the pancreas, producing insulin is called an insulinoma. And there are also other tumors building other hormones like serotonin. These are mostly localized in the midgut, in the small bowel, and others like glucagonomas, gastrinomas, building glucagon and gastrin, and many other peptides like vasointestinal peptides, so-called VPOMAs. So it's a wide range of tumors, and all these tumors contain somatostatin receptors. And you can show that this tissue is containing these receptors by using radio-labeled peptides, which bind, please remember Paul Ehrlich, to this specific receptor. And by autoradiography, you can show that this tissue is containing these receptors. And shortly after that, it was shown by the group from Krenning in the Netherlands, in Rotterdam, that if you label these peptides with another radionuclide, which is called indium-111, you can also image these tumors. So you can not only stain tissue, but you can image tumors, what we call scintigraphy. So indium octreotide or octreoscan was the first imaging agent in nuclear medicine to image this tumor. And if you give very high amounts of radioactivity, then you can even shrink these tumors. And that was also shown at this time. So this is a modern side chains or modern magic ballads, and is a schematic representation of a drug for imaging and targeted therapy. So your target can be different. It can be different receptors on the cell. All these are so-called G protein-coupled receptors. Or it can be antigens, like for antibodies. You all know, for example, an antibody which is used for treatment of breast cancer and targets the HER2 antigen. Or it can be somatostatin receptors or other receptors. The binding, the molecular address, is transmitted by the antibodies or by amino acids or by these regulatory peptides. And that what is then bound to this molecular address is what we call the reporting unit. Can be a radionuclide for imaging. I mentioned already indium. Another one which is very frequently used in nuclear medicine is called technetium-99m. Or we can use what we call PET radioisotopes, for example, gallium-68, and I will give you an example later. And as I mentioned, if we use specific radionuclides which can target these tumor cells like yttrium-90 or lutetium-177, these are so-called beta emitters which contain beta particles which destroys the tumor cell. We can use it for therapy. So imaging and therapy can be done via these magic bullets. This is one of the most frequently used peptides, which is called DOTA-TOC. So it is DOTA tier 3 octreotide. It's very similar to somatostatin. It's an 8 amino acid peptide which contains these binding regions, the same like somatostatin, and also contains this DOTA. DOTA, you will hear many times today, DOTA is just a cage which takes up the radionuclide and fixes it very stably to this peptide. So this is a cage where yttrium-90 or lutetium or also the gallium-68 is fixed to and then bound to this peptide. These neuroendocrine tumors or NETs, is not one tumor. If you are speaking about, let's say, nasopharyngeal cancer or breast cancer, it's one tumor entity. But neuroendocrine tumors are overall more than probably 100 different tumors. And they can arise everywhere in the body. Most frequently, they arise in the gastroenteropancreatic tract. That's why they are called GAP tumors. So in the stomach, small bowel, and in the pancreas, these are the most frequent localizations. But they can arise also in the lung. And neuroendocrine lung tumors are very, very on the rise. So it's now the most frequent neuroendocrine tumor we know is neuroendocrine lung cancer. And there are other tumors containing somatostatin receptors like differentiated hepatoblastomas, for example. And these neuroendocrine tumors can arise everywhere in the body. In the thymus, in the lung, in the liver itself, there are neuroendocrine cells, in the large and small bowel, and so on. So we must consider the localization of these tumors, the functional activity, that means if they are producing hormones, and the hereditary background, because it's a feature also of neuroendocrine tumors that some of these are hereditary. We call this MEN syndrome, multiple endocrine neoplasia, and these patients develop neuroendocrine tumors simultaneously or one after the other at different neuroendocrine organs, like the thyroid, the parathyroid, the pancreas, the adrenals, and the pituitary gland. So these are what we call MEN syndrome. How are neuroendocrine tumor diagnosed? Usually these patients present with what we call typical symptoms. And one typical symptom is facial flushing or diarrhea. However, in our experience, and not only in our, this is a very unspecific sign. So many patients, have diarrhea, but they are treated like infectious bowel disease. Or if they have flushing, many doctors think probably, too much alcohol. And they don't think of a carcinoid tumor, And only if you think about it, of course, you can diagnose it and probably measure hormones in blood, which then tell you that it's a neuroendocrine tumor. However, about 40 to 50% of this neuroendocrine tumor is what we call non-functional. They are not producing hormones. So There is no way for measuring it. However, if you have the suspicion or the proof already, you can then use diagnostic modalities to localize the tumor. Most frequently, the first method is ultrasound, sonography, to look at liver, and the abdomen, or endoscopy, where you look at the stomach, the small bowel, large bowel, and so on. MRI and CAT scan are also used, and also somatostatin receptor scintigraphy, what I already mentioned, which should be the first method in many cases, but in reality it's most frequently used as a last method to localize these tumors. And as I mentioned, most frequently these tumors are localized in the foregut, which is, for example, lungs, stomach, pancreas, the midgut, the small bowel, and the hindgut, which is large bowel. Now, when you have performed the localization of this tumor, you can also treat them. First, by surgery, but if there are, besides the primary tumor metastases, you have to find other ways to treat these tumors. These are typical patients, and patients allowed me to show these images with facial flushing. You need this reddening around the nose and the swollen eyes here, what we call chemosis. And this patient, who was diagnosed by his family doctor as a heavy drinker, because he developed this flushing and had no other symptoms, but was misdiagnosed. And this is another very good example how unspecific, these what we call morphological methods like ultrasound are. I mean, ultrasound is a very good method, but it cannot tell you what kind of tissue is it. And this is a lesion in the liver, in February 1999, which was first diagnosed as a hemangioma, which is a benign, lesion in the liver, which is very frequent. Then it grew a little bit, but not very much, as you can see here. And still doctors thought, okay, it's a hemangioma. But finally, when it grew more and more, they made a biopsy out of that. And I show you the growth characteristics over 6 years here. So for a long time it was nearly stable. Then it started growing more and more. And it was a liver metastasis of a neuroendocrine tumor, right? So ultrasound or CT or MRI are not telling you what kind of tissue you are seeing. You are seeing tissue, you are seeing a tumor mass or a mass, but you cannot really tell. Whereas scintigraphy using these peptides, which bind to specific receptors, can tell you exactly if there is this lesion in the liver, and there are more than one lesion here seen. These are neuroendocrine tumor cells with a high content of the somatostatin receptors. So this is a scan, a method which we have developed with a technetium-labeled peptide, which is much faster than the octreoscan, which goes after 1 hour. For those doctors here in the room who are interested, there is an article, a review we have published in Seminars of Nuclear Medicine on imaging of neuroendocrine tumors, and it shows you here that there are many different kind of receptors. I'm talking today only on the somatostatin receptors, but there are many others like gastrin receptors, for example. Now this octreoscan has been introduced in 1992 in clinical practice and is still used around the world. And I call it today, it's an old standard for imaging of neuroendocrine tumors. Why is it an old standard? Because the sensitivity is much less than when we use, for example, the somatostatin receptor PET or PET-CT. This is shown in this example in a patient with metastasis in the liver of neuroendocrine tumor, and you see very faintly that there are some lesions here outside the liver. And when you do what we call a skeletal scintigraphy, you see that these lesions are, for example, in the skull, in the ribs here. But when you are doing a PET scan, you see many, many more lesions. Now, if you compare how many lesions you see here as compared to the octreoscan, it's about 300% more of lesions. So PET is a much more sensitive method to localize the disease. And for that, we have developed a specific, PET isotope, which is called gallium-68. And this gallium-68 comes from a radionuclide which is called germanium-68 with a long half-life. And then you can use what we call an elution from this as gallium-68. And this is a very convenient production which can be done in any, nuclear medicine department. So the same peptide may be also labeled with lutetium or yttrium-90 for radionuclide therapy. Now, together with a group in Mainz with Professor Rösch, about 5 years ago, we developed this gallium-68 generator system for, labeling of peptides with PET isotopes, and could show later on that this also can be used in a GMP-produced way. There is now a company providing that, which is called Eckert & Ziegler in Germany, and they can provide this as a, industrial-produced generator, not homemade like we did it a long time ago. What are the advantages of PET-CT? Now, this provides functional and anatomical information. You have the information on the receptor content and also the exact localization. It has a short acquisition time. That means for the patient it lasts about 20 minutes, to scan the whole body. Whereas with the octoscan you have to come 24 hours, 48 hours, 72 hours, and each time it takes half an hour or more to scan the body. And you get what we call quantitative data. You are not only looking at images, but you can really measure how much radioactivity is in your tumor. And this is the first study we did in Bad Berka in July 2004. The patient with a neuroendocrine pancreatic tumor you are seeing here with a lot of liver metastases. And I want to point you to this lesion. Now, if you are just looking at the image, it's very difficult to say where it is, because this is a transversal slice of this lesion here, because there is nothing around. There is no anatomical structure, because these peptides are so specifically targeting only to these receptors. Now we need a guide, so to say, like when you are sailing on an ocean with a ship, you need what we call a sextant, to know where you are. And our sextant is a CT scan. And when we fuse these two images together, you see that the lesion is here in a lymph node, okay, and for example, not in the bone like here. So you can get a very exact localization of the lesion by this PET-CT scan. And I think this generator really is a significant step towards the routine medical use of PET isotopes. And I understood that it's now also available in Singapore. At least one of the radiochemists from Singapore was visiting our department and studying this technology. And I think it will soon be available in the PET center, the PET and cardiac imaging center here, and will be provided to patients here. So a little bit on the diagnosis of this neuroendocrine tumors by receptor PET-CT. One feature I mentioned already is that you can scan the whole body and all different organs. So that's what we call a one-stop shop, You can diagnose the liver, the bone, the lymph nodes, the bowel, everything in one procedure. You don't need 10 different diagnostic procedures. You can find, in many cases, unknown primary tumors, CAP, cancer of unknown provenience, and you can evaluate the receptor status before PRRT, Peptide Receptor Radiotherapy therapy, and, evaluate the patient if he's a candidate for this kind of therapy. This is a typical neuroendocrine primary tumor in the small bowel. And you see it's very small. It's sometimes these are less than 1 centimeter, less than 10 millimeter in size. But the metastases, this is a lymph node metastasis in the mesenterium, can be tremendous size. Though we have patients with 10, 15 centimeter liver metastases, and the primary tumor still not found. This is a very specific feature of these neuroendocrine tumors. Usually the primary tumor, let's say if you have a tumor in the head and neck area, the primary tumor is growing and then it sets metastasis. Here, the tumor can be very, very small and the metastases are growing, but the primary tumor remains small. So we have many patients, up to 30, 40%, with unknown primary tumor localization. And PET helps you to find this primary tumor. On the left, you see here a whole body PET CT scan from the head here, to the lower thigh. You see here the liver, you see the spleen, you see the bladder with excreted activity, and then you see different lesions. Here one in the liver, here is something in the abdomen, here is probably something in the thigh. Now with PET-CT you really can pinpoint this lesion. For example, this lesion here corresponds to a primary tumor which was previously unknown, by the way, in the small bowel. This lesion here corresponds to a small lymph node metastasis which you hardly can see on the CT scan, but which takes up, as you can see here, a lot of radioactivity. And this lesion here is corresponding to a bone metastasis. You can even say it's a bone marrow metastasis, because you see here the white thing on the CT scan is a bone, and this is a bone marrow, and it's more in the bone marrow than in the bone. That also explains why we are so much more sensitive with PET-CT as compared to, for example, skeletal scintigraphy. We can even detect lesions which are still in the bone marrow and not involving the bone. Okay, this is another example of a patient with a lot of liver metastases. You see them here. And again, this is a non-functional, peptide, non-hormone producing neuroendocrine tumor. And again, a CAP syndrome. So where is the primary tumor? This is the liver, these are the kidneys, the spleen, and this is what we call the pancreas, And the pancreas is absolutely normal on CT scan here. But if you look a little bit enlarged here on the PET scan, you see that there is a lesion in the pancreatic tail, just adjacent to the spleen here. So you can see very small lesions which are not seen on the CT scan. And this is another example of a 6 millimeter pancreatic neuroendocrine tumor detected by receptor PET-CT, not seen on the CT scan. And again, if you look at this whole body, you see it lighting up, like a needle in a haystack. It's difficult to interpret CT scans because there are several hundred slices. You have to look at each slice, but it's quite easy, to interpret the PET scan because you have only the needle in the haystack. So restaging and follow-up is another indication. When the patient has been diagnosed and treated, and then there is aftercare or follow-up of the patient, we measure what we call tumor markers. You remember that Paul Ehrlich already did that, recognize that there are markers given into the blood. And some of these markers are chromogranin or CGA, serotonin, calcitonin, glucagon, and other hormones we can measure. And now if the patient is presenting in the follow-up with the rising tumor markers, of course you want to know where is the recurrence. Is there a local recurrence? Is this in lymph node, or is it in the liver or in the bone, or where is it? And usually up to now we were using the octoscan to localize this disease. And this is an example of a patient after resection of a pancreatic neuroendocrine tumor and splenectomy and a single liver metastasis, and then he presented again with the increasing chromogranin A level. And if you look at the scan here, at the octoscan, this is the kidney, this is another kidney, this is some bowel, this is a liver. You might think that in the upper part of the liver there might be something, but they did a SPECT scan, a tomographic scan, and there was no lesion. But on the PET scan in the same patient, you see the lesion here very clearly, which was, by the way, hidden and masked by kidney activity here. And in addition, we detected a small lesion here in the stomach, which was previously not known and confirmed by endoscopy to be a metastasis and tumor infiltration of the stomach here. This is another patient I remember very well, a young lady who had a really diagnostic odyssey. In many, I think more than 4 different hospitals, she presented with a rising calcitonin level. Calcitonin is a hormone which is usually produced by cells in the thyroid, but she had a pancreatic neuroendocrine cancer producing this hormone, and the calcitonin was rising and rising, and nobody knew where the tumor is localized. So finally she came to our center and we diagnosed a liver metastasis here in this segment, and for the surgeon we fused the PET-CT and the MRI together to show the relation to the vascular structure here, and finally she could be operated, and the surgeon found a 1.5 centimeter lesion in the liver, and fortunate for the patient, now 2 years later in the follow-up she is free of disease, so the metastasis could be completely removed, and the only thing which is left here is a surgical clip. So this shows that with PET-CT we are more sensitive than the usual CT, MRI, ultrasound imaging modalities. These are other examples where we can see a liver metastasis which is seen on the PET scan but not on the CT scan, or lymph node metastasis hardly to be seen on the CT scan, and again a small bone metastasis detected here. Sometimes we recognize even very rare metastases, for example, in the heart. I don't know if any one of you have heard of a metastasis in a human heart, but neuroendocrine tumor metastasized to the heart. And by PET-CT, we have now 30 patients with metastasis to the heart among more than 550 we have studied. And you see here the heart muscle, and there is a metastasis in the lateral wall of the heart, or here in this other case, you see it in the septum. And this is again a patient with a septum metastasis. And can we treat this metastasis by receptor radionuclide therapy? Yes, we can do it. And as you can see here, after one cycle of therapy, the metastasis completely disappears. So one of the most important indications, of course, is the evaluation of the patient before peptide receptor radionuclide therapy, because we can get these quantitative measurements, or in nuclear medicine we call this SUV, standardized uptake values. And this SUV is given here, usually in normal tissue is about 1 or less than 1. So in tumors, like in this glomus tumor, by the way, which had received external beam radiation of 50 Gray before, which was completely useless in this case, had a SUV of 109. So 109 more than normal tissue. And you also see that the most frequently used tracer for PET is FDG, is labeled glucose or fluorodeoxyglucose, is showing no metabolic activity of this tumor. So with FDG you would even miss this tumor. However, with gallium-68 labeled somatostatin receptor imaging, you see a very, very high uptake, and we treated then this patient with yttrium-90 dotatate in this case, and she showed a very nice response. This is another case of a lymph node metastasis. This is a diaphragm, what you see here. This is the aortic artery, and there is a lymph node in the retrocrural region seen here with a very high uptake, 152. This is the highest uptake we have ever measured. So when we check this in different primary tumors, liver metastasis, lymph nodes, and so on, you see that the range is very wide, from 3.3 to 105. So it's not only looking at the image, at an ocular scan and saying it's positive. That means nothing for me. Positive can be 3.3, can be 105. But with receptor PET-CT, we are really able to measure how much activity is going to the tumor, and that's like, radiation therapy planning. You have to have your volume, and you have to have your radiation time, and then you can really plan what you want to do, and this is very important. And that is really important is shown in this slide, where we have compared the uptake in different tumors. And as higher the uptake, as higher this SUV max, as better the tumor response. So as more activity is going to the tumor, as more dose the tumor receives, as better the therapy response, which is very clear. Evaluation of therapy response is usually done with what we call RECIST criteria. So these RECIST criteria are only based on tumor diameter. I will show you an example. It's easier than to explain all of that. This is again a liver shown here on CT scan, okay? And you see metastases in the liver, like here. Now you can measure that very accurately, as exact as a millimeter or so. And you can give a size of this lesion. But what does it tell you? I mean, there's another one, there's another one. And you see some of these metastases are gray inside. That means they are necrotic. They contain a lot of water. And for example, here about 50% of the lesion is necrotic, whereas here there is very little necrosis. Though the tumor diameter tells you really not very much, it just tells you there is a lesion of this size, but it is viable tumor, if it is active tumor or not, is not shown on these images. Whereas with a PET-CT, we cannot only look at the tumor diameter, but also, as I said, on this uptake in the tumor. And we can also use it for therapy control. After one therapy, the metastasis is disappearing here on CT scan. After 2 therapy cycles, there is no tumor anymore. And this lasted about 1 year, and then small other metastases were coming up. So we can also use this very nice for therapy response. And molecular response, metabolism always precede morphology. This is shown in this case with this is what we call the sacrum, and there is a tumor in front of the sacrum. And if you look at the CT scans, this is about 1.5 years, You don't see any significant change. If you look at the PET scan, you see a reduction of uptake here. But if you measure that with the SUV, you can very easily and much earlier say there is a tumor response to therapy than when just looking at the images. So what kind of tumors we can image aside from neuroendocrine classical gastroenteropancreatic tumors is listed here. Meningioma is a brain tumor or a tumor occurring in the skull. Actually, it's not going out from the skin but from the meningia. Esthesioneuroblastoma is a very rare tumor which occurs in the frequently in the sinus cavity here. Then medullary thyroid cancer, paraganglioma, pheochromocytoma, adrenal tumor, thymus cancer, glomus tumors I have shown, and many others. So other molecular imaging probes aside from the gallium-68 labeled peptides, I will very shortly mention only FDG and fluordopa. And this is, dependent on what we call the proliferation rate of the tumor. So how fast is a tumor dividing? And that can be measured with a Ki67 antigen. Ki comes from Kiel, which is a German city, and there was a pathologist who developed an antibody for staining these tissues. And as more of these cells are stained, as higher the proliferation rate. So, for example, you see here many cells stained, which is a Ki67 of 30%, and here are very little cells stained. So depending on the Ki67, if it is high, you should use FDG as a metabolic tumor marker, and this is shown here in a patient with liver metastases where FDG is strikingly positive and gallium-68 is only faintly positive. So if there is a high proliferation, one has to prefer FDG. So in conclusion, on the imaging part, receptor PET-CT using somatostatin analogs enables the molecular imaging of neuroendocrine tumors with very high diagnostic sensitivity and specificity. In our center, we have now performed more than 3,000 studies. The advantages are that we have quantitative data, a very fast protocol which is patient-friendly. I mean, everything is finished within 1.5 hours. Low radiation burden. It's less than Octreoscan. We can use it daily, and what is also important in our times is to contain healthcare costs, so costs are less than for octreoscopy imaging. And I think it's a new gold standard concerning the sensitivity. There are many other gallium-68 labeled substances in clinical use now, and you see many of these were developed or first used in Bad Berka. Time does not allow to go into detail in this.